This video is on gonioscopy. This is the fifth part of gonioscopy. In this video, I'm going to read the gonioscopy from Arwind's, and this is the second day. I'm reading from Arwind. Yesterday, I read first 4 pages of gonioscopy from Arwind's textbook of glaucoma. Today, I'm going to proceed with page number 131. So we'll start. Which lens to use? The best choice of gonioscope is the subject of much debate. Lenses that are steeper than the corneal curvature Goldman style require coupling fluid, while those that are less curved do not. Many ophthalmologists feel the 4-mirror lenses have the advantage of rapidity in identifying normal, open angles, avoid the need for contact media, and allow more effective compression examination. In contrast, the Goldman style lenses offer a more stable, clearer view. A very popular lens is for the ocular instrument MagnaView, a magnifying Goldman style lens. Carbomer 90 or hydroxy profile methyl cellulose 0.5% are suitable coupling agents. Dynamic examinations are to some extent possible with the Goldman type lenses. The possibility of artifact occurring from the use of one or the other is again a matter of debate. The examiner should use the lens that she or he is comfortable with and gives the best view in circumstances. Glaucoma specialists should certainly have access to both. Direct view lenses such as the Kippe lens are generally only used in the operating theatre, but are able to give a wide-field direct view of the angle. The procedures: adequate anesthesia, patient positioning and examination. Before even touching the patient, it is important to obtain full topical anesthesia that sufficient for applanation tonometry is often inadequate for successful pain-free gonioscopy. It is vital to have the patient, slit lamp and doctor carefully positioned for what might be lengthy, detailed assessment. A rest for the ophthalmologist's elbow will prove invaluable. It is also important to give the patient a clear explanation of what to expect. They may well never have had any ocular examination before and can feel very threatened by a gonioscope in darkened room. Illumination. It is absolutely essential to have the lowest possible background room illumination for error-free angle examination. The lights must be off, the blinds closed, curtains down, and even the Snellen chart dimmed. Just a small amount of light-induced pupillary miosis can pull a closed angle open. Many a case of angle closure has been missed because the room lights were on table 5. For the same reasons, the slit lamp beam that is used should be the dimmest that permits landmark structures to be seen. With a standard hack straight, it is usual to perform initial examination with a filter in and a thin 1mm beam. The beam should not cross the pupillary margin. It may be necessary to brighten the beam temporarily in order to identify reliably the corneal wedge, but then dim it again to look for iridotrabecular contact. Lens insertion. The larger Goldman style lenses such as the high magnification MagnaView can be awkward to insert in some patients. Inserting a gonio lens is made easier by asking the patient to look upwards, then gently insert the lens with its upper edge holding the upper lid margin to prevent any reflex blink, being very careful not to place any pressure on the cornea. The patient should then look directly ahead or at the examiner's contralateral ear with the other eye. In very sensitive patients with a lot of reflex blepharospasm, it may be necessary to stop, check there is adequate anesthesia and repeat the process with fresh coupling fluid if used. Figure 5. Which lens to use? Now there are direct lenses and indirect contact lenses for gonioscopy. Direct lenses, prototype Kippe lens and that Corilla Bats one. Richard Schaffer, Kippe, Legend, and Swan Jacob and B.A. Barker. Yeah. So these are the direct gonio lenses we studied from Shields when I read Gonioscopy in part 1 of Gonioscopy from Shields. There I have discussed different types of direct contact lenses from Shields textbook of Glaucoma 6th edition. So these are the direct contact lenses, and indirect contact lenses are 4 mirrored, single mirrored and 2 mirrored or 3 mirrored. And 4 mirror lenses, they can be used for indentational gonioscopy to differentiate synachial closure and a positional closure in cases of the iridotrabecular or iridocorneal contact. And which lens to use? So if we want the rapid view, obviously 4 mirror contact lenses are comfortable for the patient and for the examiner also. Why for the patient? Because the posterior curvature, as I yesterday said, the posterior curvature is similar to the anterior curvature of the cornea, and there is no gap between the posterior curvature of the indirect contact lenses, 4 mirrored contact lenses, and the anterior surface of the cornea and anterior curvature of the cornea. So we don't need the coupling substance. So that viscoelastic substance, the sticky sensation, the blurring of the vision after the procedure because of the viscoelastic substance that remains on the surface of the eye even after washing it, it remains for a while, and that discomfort, that sticky sensation, blurring of the vision, and even rotating the lens, that causes discomfort to the patient. These 3 things can be avoided with 4 mirror lenses. And these 4 mirror lenses in size 4 mirror, the mirrors are inclined at an angle of 64 degrees, so we don't need to rotate the lens in order to view the angles. So depending upon the need, usually for rapid procedure, it's good to use 4 mirror lenses. We can use Goldman mirror lenses. Then we modified Goldman lenses. Nowadays they are available in different radii and posterior curvatures. So the contact surface is, so we don't, the posterior curvature is similar to that of the cornea in modified Goldman lenses, and we don't need the coupling substance for that. We don't need the coupling substance or bridging substance to fill the gap between the cornea and the posterior curvature of the Goldman lens, modified Goldman lens. So, as per the patient's comfort, examiners, and availability, it's very important. Availability of these lenses at the institute, or you should buy your own lenses. The procedure I'm not gonna repeat in words. It's better that direct gonioscopy video I didn't find. I got only 2 pictures from Atlas Gonioscopy, which are present on the site of www.gonioscopy.org. On that site, there are so many beautiful videos. My God, I watched 10-15 videos today, and it's beautifully given. It's like very good. It's a good site to study gonioscopy. But no video, no site is a substitute for standard textbooks. So these are only supplementary. You should read the standard textbooks, and for better practical knowledge and better comprehension, you should refer these videos and the sites, even the articles. Now the procedural direct gonioscopy identified, I found the 2 pictures that only I'll share here at the end of this video. And then indirect gonioscopy, today only I saw the indirect gonioscopy with 4 mirror lens on www.gonioscopy.org site, and that video I'll just go for screen recording if it is possible, and I'll just share that video here, how to do indirect gonioscopy, the technique, because it's better to see rather than just verbalize or articulate it, because visual stimulation has the better comprehension than the auditory, and we can remember the things better if you see them. So I'm gonna share the video rather than repeating the paragraphs regarding the technique of gonioscopy. So indirect gonioscopy with the folder, I'll just share that video. Then very important thing, the room should be darkened because room illumination, they are saying that even the room illumination can make you miss the angle closure glaucoma or angle closure diagnosis. And the slit lamp beam, it should be narrow, it should not fall even on the pupillary margin, forget about the pupillary area also. It should not fall in the pupillary area and also on the pupillary edge in order to prevent the constriction of the pupil, because the constriction of the pupil or the meiosis, it causes opening of the angle. So even the closed angle will appear open because of the meiosis. Gonioscopic anatomy. The antechamber angle is the recess between the iris on one side and the corneal endothelium, shawl-base line, tubercular meshwork, scleral spur, and ciliary body face on the other. The root of the iris usually inserts into the ciliary body face, but the exact level is variable. The iris itself is highly mobile and can vary in profile a great deal, with a degree of pupil block or position of more posterior structures such as ciliary processes or lens. Starting at the root of the iris and progressing anteriorly toward the cornea, the following structures can be identified by gonioscopy in a normal angle in an adult. Ciliary body band. This structure is the portion of ciliary body that is visible in the anterior chamber as a result of the iris insertion into the ciliary body. The width of band depends on the level of iris insertion and tends to be wider in myopia and narrower in hyperopia. The color of the band is usually grey or dark brown. Scleral spur. This is the posterior lip of scleral sulcus, which is attached to the ciliary body posteriorly and the corneal scleral meshwork anteriorly. It is usually seen as a prominent white line between the ciliary body band and functional tubercular meshwork, unless it is obscured by dense uveal meshwork or excessive pigment dispersion. Variable numbers of fine pigmented strands may frequently be seen crossing the scleral spur from the iris root to the functional meshwork. These are referred to as iris processes and represent thickening of the posterior uveal meshwork. Functional tubercular meshwork. This is seen as a pigmented band just anterior to the scleral spur. Although the tubercular meshwork actually extends from the iris root to shawl-base line, it may be considered in two portions, the anterior part between shawl-base line and the anterior edge of the Schlemm's canal, which is involved to a lesser degree in aqueous outflow. The posterior or functional part, which is the remainder of the meshwork and is the primary site of aqueous outflow, is spatially that portion immediately adjacent to Schlemm's canal. The posterior, more functional part of the tubercular meshwork is usually pigmented. Though variably so, in poorly pigmented eyes, it can be hard to distinguish the tubercular meshwork on color alone, and it is essential to be able to identify the corneoscleral junction. The appearance of the functional meshwork varies considerably depending on the amount and distribution of pigment deposition. It has no pigment at birth, but color develops with age from faint tan to dark brown, depending on the degree of pigment dispersion in the anterior chamber. The distribution of pigment may be homogeneous for 360 degrees in some eyes and irregular in others. In functional portion of the meshwork, especially when lightly pigmented, blood reflux in Schlemm's canal may sometimes be seen as a red band. Shawl-base line. This is the junction between the anterior chamber angle structures and the cornea. It is a glistening white line just anterior to the meshwork, which represents the posterior-most termination of Descemet's membrane. There is also a transition from the scleral curvature to the steeper corneal curvature at this line, which can cause settling of pigment in this area, especially inferiorly. Normal blood vessels. Blood vessels are normally not seen in the angle, although loops from the major arterial circle may appear in front of the ciliary body band and less commonly over the scleral spur and tubercular meshwork. These vessels typically take a circumferential route in the angle. In addition, an anterior ciliary artery may occasionally be seen as more radially oriented vessel in the ciliary body band of lightly pigmented eyes. Circumferential and radial vessels may also occasionally be seen in the peripheral iris of lightly colored eyes. Radial vessels are more common in the peripheral iris, whereas circumferential type are more common on the ciliary body. Iris processes are fine physiological extensions of peripheral iris to the tubercular meshwork that are highly variable from individual to individual. The important distinction is between normal iris processes and peripheral anterior synecdoche. Peripheral anterior synecdoche usually broader and cause an irregularity in the contour of the surface of the iris. So, gonioscopy anatomy, what we can see normally on the gonioscopy. So, it's the ciliary body band from posterior to the anterior. From posterior to the anterior, following structures can be seen. So, these are ciliary body band, scleral spur, tubercular meshwork, short baseline. Now, what is ciliary body band? Ciliary body band means it is the anterior face of the ciliary body, including the longitudinal muscles, circular fibers and radial fibers. But longitudinal muscle insertion is from the scleral spur to the suprachoroidal lamina beyond the equator, even beyond the equator. So it is like this. It is like this. Circular muscles are like this and radial muscles are like this. So anterior face of the ciliary body band, it will include the circular and radial muscle fibers, and the longitudinal muscle fibers, their view is obscured because of the scleral spur. So ciliary body band, it is the anterior face of the ciliary body, mostly prominently formed by the circular and radial muscles of the ciliary body. And the ciliary body band visibility depends upon the level of the iris insertion. In myopia, the angle depth is, the antechamber depth is deeper, and in hyperopia it is shallower. Depending upon that, the ciliary body band is wider in or more prominently seen in myopic patients, in hyperopic patient. In hyperopic patients, a small portion of the ciliary body, it is not wider in hypermyopia. It is not wider in hyperopia. Now, scleral spur. Scleral spur, it is the posterior projection of the scleral sulcus. Now, what is the scleral sulcus? I have already discussed it when I was reading Gonioscopy from Shield's textbook of glaucoma. In that, I have discussed what is scleral spur, but again, as a revision, I would like to talk about scleral spur. Scleral spur, it is the projecting part of the posterior edge of the scleral sulcus. Now, what is scleral sulcus? Scleral sulcus, it is present, it is a groove that is present on the inner surface of the limbus. Now, what is limbus? That I'll talk about. What is scleral sulcus also, I'll share the pictures. And at the end of this video, what is the corneal wedge? That also I have what is corneal edge technique? I have already shared that thing in the previous video, but once again for a revision, I'll add that video also, because the landmarks and the gonioscopic anatomy is very nicely given. You can see the 3D view, you know. It's just like this. It's a 2D view here, but there is a 3D view like this. So the scleral sulcus, how it's gonna form the Schleim's canal, that also we can imagine and we can see clearly. It's very good for comprehension, that video. That's why I think your mentor should be like super specialist, I feel, because they have the deeper knowledge about that subject. And that video is from glaucoma specialist, and he has very nicely given that video, like how to look for the corneal wedge. Your mentor should be nice. If the quality of your skills, they come from your mentor. If you are not skilled enough, if you are not knowledgeable enough, because to me, every person who passes MBBS, every person who is postgraduate, okay, every medical surgical student, I feel they're intelligent. They're very intelligent, and that's why they have passed the MBBS exam and they have passed post-graduation exam. They have that concentration level, they have that determination and willpower. So every student is bright, it is the work of a teacher to keep that interest alive and to make them skilled enough to keep their interest in the field that they are in. And they should be generous, man. They should not be jealous of the students group. Means if I'm a teacher, I would love my teachers to outgrow me. It's not like by suppressing me, but I would like, some students, like some juniors also can bully you, and some students can also bully you. It's the other thing. But I feel like a teacher who is generous, who is very skilled, who is knowledgeable, can make students' life, like the students' future in that field is very bright because of the mentor, because of the guide. You should get the teacher. I think I'm not very blessed enough to get that mentor in my life. Also, whenever you want any, I feel like whenever you want to be successful in any field, you need health, healthy body, healthy mind. Second thing, finances, because without money you cannot buy books, you cannot have internet, you cannot do anything without money. You cannot even live, you cannot even have food. So even with finances, you can choose a better place to study, better place to live, better food to have, you know. So money is very important in life. You can start your own business. You don't have to work under any seriously asshole. And then third thing is, first thing is health. Second thing is money. Third thing is mentor. Mentor is very important. And fourth is right hard work. Right smart hard work is very important. And that hardworking and persistent attitude, it should be present in you. And I think every MBBS passed out student and every postgraduate student has that concentration level and has that willpower and hardworking ability and tolerance enough to shine in life and to shine in their career field. So it's the job of teacher, it's the job of the mentor to keep their interest alive and to make them skilled and knowledgeable enough. I don't have that mentor in my life, that's why I'm just resting in the house for 3 years. But anyways, one day it will change. So I hope you all be blessed with a very nice mentor, and when I become skilled in vitreoretinal surgery, and also after vitreoretinal surgery fellowship, after 5 years of practice, even I'll go for other super specialty. I'll keep on learning till I die. I'm gonna learn so many things, even music, dance, and main thing is my this career field. Surgery is my passion. Compassion, it's out of compassion. So yeah. So I hope you all be blessed with a very good mentor, good financial support, a very good health, and I have no doubt that every MBBS student, every postgraduate student has that willpower, concentration, and hardworking ability. So never underestimate, because there are so many people who pull you down and they want to drag even they want to drag you down. They don't want you to feel confident in your own skin, in your own brain, in your own thoughts. They don't want you to be confident. So be confident and have trust in yourself, because you have passed MBBS examination. You are doing post graduation, or you have done post graduation. So you have that spark, and nobody can just underestimate your intelligence or talent. So even if your mentor is underestimating you or criticizing you sarcastically, that's not a right one for you, primarily. Because I have seen so many teachers, taunting teachers in my life. I have seen my school teachers, high school teachers were the best. After that, I didn't have very good teachers. But anyways, but teachers make your future bright, because you are already bright. You have passed postgraduate, you have done MBBS, you are doing post graduation, or you have done post graduation. You are smart enough. So ciliary body band, scleral scope. Okay, now scleral sulcus. So scleral sulcus. So that glaucoma specialist I was talking. So have super speciality. I feel like even after specialty, you go for rather than going for general ophthalmology. If you didn't get the enough exposure, um, I honestly feel that they should teach you everything phaco surgery. You don't have to go for general training once again and wasted 1.5 year of life and even financial loss you should not face to repeat the same thing. They should teach you phaco surgery, they should teach you small incisional cataract surgery at least 250 each type to you. They should give you that these kinds of surgery in the institute, and they should make you independent surgeon. You should know how to do small incisional cataract surgery and phaco surgery. You should be independent in that once you complete your 3 years of post graduation. And I agree that vitreoretina will take time, like 2 years. Even plastic surgery, oculoplasty will take 1.5 year. Cornea, okay, 1 year. Glaucoma, 1 year. But honestly, I feel if they just give me more, like people, they don't have. Not every student, different students having different learning curves. Like not everybody is uh, born with the talent. Some people are born with the talent. Some people have that fast learning curve. So I'm very sure that I have seen myself. I have the fast learning curve, and so many people were jealous of that thing. And some jealous people even put obstacles like 3 years gap. 2.5 years gap is too much. It's out of people's jealousy most of the times. So let it be. So I feel you should go for super specialty either in glaucoma, cornea. I feel you should know everything. Everything means everything, and you should not waste 1.5 year for to learn phaco surgery or to master small incisional cataract surgery. You should not waste 1.5 year because they pay you only 10,000 or 20,000 or 30,000. This is like unjust to me. It's like absolutely unjust. I didn't accept that thing. I decided that Victoria surgery fellowship 2 years is okay. 1.5 year to 2 years is okay. Even 1 year is okay if they, because I'm hardworking enough. If they give me these many surgeries, I am ready to work hard and I'm ready to accomplish the 2 years course in 1 year only if they allow. But private institutes, they want to run business, and they don't want you to be, honestly, they don't want you to surpass them, honestly. So let it be. But have the super speciality. General knowledge, they should give you general skills, phaco and small incisional cataract surgeries, even trap surgeries, I feel. They should give you during, at least during senior residency, they should give you in 1 year, like trabeculectomies, they should give you. And we should not wait for that. Like in our institute, we started learning gonioscopy in second year. I feel it should start right away from the third month. Yeah, after third month. Even one ophthalmologist, I think he's Terry Thomas. He's a glaucoma specialist, I guess. I have read his article. I interacted with him for just 2 minutes. Even I had recorded that thing because to me he was very famous and good. So I recorded my conversation with him. He was like, "Did you do your gonioscopy for when you started doing gonioscopy?" I said in the second year of post graduation. He said, "No, why so late?" Means no, I think he addressed it to everyone. He asked for like they should give you gonioscopy, means you should start practicing gonioscopy at third month of your joining itself. So I feel you're skilled enough, you're smart enough. Why to wait? Why they make you wait? I don't understand it. I don't agree with so many things. The system is just uh, the system, education system is like a slavery system, and it's very slow. It's a very slow process. It's a very it just makes you rust. I feel it just makes you rust. It just wastes your time, and yeah. Really. So scleral spur, it is that scleral sulcus. I'll just read the limbal anatomy in short. It's already 30 minutes. I'll just read limbal anatomy, and so you will understand what is scleral spur. First, scleral spur, it is a posterior projecting part on the inner surface of the limbus. First, the scleral sulcus, it is a groove that is present on the inner surface of the limbus. So for that, I'll read the limbal anatomy after this paragraph. And the scleral sulcus, it has got the anterior edge. It extends from the short base line, that is the termination of the descendants membrane, to the scleral spore, that is the projecting part of the scleral sulcus, posteriorly. And that is called as the scleral spore. That posterior projecting part is called as scleral spore. And this scleral sulcus, it is converted into a canal, Schlimm's canal, by the breaching trabecular meshwork. So scleral spore, it is a white band. It is seen as a prominent white band, and ciliary body band, it is seen as grey or dark brown band. And functional trabecular meshwork. The trabecular meshwork anterior and posterior. Anterior is non-functional, they are saying, irrelatively, and posterior is functional and pigmented. Anterior extends from the short base line or the end of the descendants membrane to the anterior edge of the Schlimm's canal, and from the anterior edge of the Schlimm's canal to the root of the iris, it is the posterior functional part, but the root of but it is visible till the scleral spore. And short base line, it is the junction between the antechamberal angle structures and the cornea. It is present at the termination of the descendants membrane, and it is more prominent in the Eisenfeld-Rieger syndrome, Eisenfeld anomaly, and the prominent short base line, it is called as posterior embryotox, and that also I'll share. Yeah. Now they have talked about the normal blood vessels, so you should be able to see if there are blood vessels at the angle. You should see whether it is a neovascularization or normal angles, okay, or normal angle vessels. The vessels at the ciliary body, they are vessels at the ciliary body. Vessels at the ciliary body, they are circumferential, and on the root of the iris, they are radial. Now I'll just see the gonioscopic landmarks. Corneal wedge and level of contact and looking over the heel, estimate width, iris profile, and structure seen in dentational gonioscopy. These next 4 pages I'll read tomorrow because it's already 30 minutes and my cell is again hot. It's on high, its temperature is high now, so I have to stop here. Only I'll read the corneal edge gonioscopic landmark because I'm gonna share this video. And after that, I'll read the nimbus anatomy in 5 minutes. Gonioscopic landmarks. The most important step in gonioscopy to identify is the corneal wedge. To find this, the illumination beam must be slanted off axis to be able to view simultaneously the corneal epithelial and endothelial reflections. For superior and inferior angles, the illumination column should be horizontally offset from the axis of the microscope and the beam vertical. For nasal and temporal angles, the beam should be horizontal and offset vertically by tilting the illumination column. The corneal wedge is that point at which the two lines converge. Its apex marks termination of the descendants membrane, the site of short base line. This is formed by the junction of the beam on the endothelium or trabecular meshwork surface and the beam falling across the corneoscleral junction. The trabecular meshwork starts immediately posterior to this structure. Its location helps confidently identify where meshwork starts, even in densely pigmented angles or those with extensive iris processes. With experience, it can be seen that the corneal wedge may be acute or obtuse in its approach. Once this is realized, it can be seen in almost all cases without difficulty, provided the angle is open. If the apex of the corneal wedge is not visible, then iris is obscuring the trabecular meshwork. If neither epithelial nor epithelial line is visible, then there will be obscuring corneal panels or scarring. The next step is to identify whether there is iridotrabecular contact and assess the angular width between the peripheral iris and the trabecular meshwork of peripheral cornea. So there is one table and 2 figures that I'll see. Comparison between Goldman and Zeiss gonioscopic lenses. These are figures. I don't think it is very important, but still, once I read. Type of lens, diameter of corneal contact, Goldman single, Goldman 3 mirror, Goldman Zeiss 4 mirror. Diameter of corneal contact 12 millimeter, 12 millimeter, Goldman Zeiss 4 mirror, 9 millimeter. Corneal contact, see, it is smaller, 9 millimeter, and Goldman single and Goldman 3 is 12 millimeter, 12 millimeter. It is larger, so it will, on indentation, it will indent the angle itself and it will cause the distortion of the angle structures. While with Goldman Zeiss 4 mirror lens, as the area of the contact is less, it is 9 millimeter, it will indent the cornea. On indentation, it pushes the aqueous humor into the angle, and this property is very important in identifying the oppositional closure versus synachial closure. Oppositional closure, obviously on indentation, the angle will open, and on synachial closure, it won't open. Overall diameter 15 millimeter, 18 millimeter, 9 millimeter. 9, it's easy to remember. Size of the ring 1.5 millimeter, 3 millimeter, 9. Mirror angulation degrees 62, 59, and 64 degrees. Mirror height 70 millimeter, 12 millimeter, 12 millimeter. Mirror height, if the height is more, the depth seen is more. Mirror height 70 millimeter, 17 millimeter, 12 millimeter, 12 millimeter. Distance from central cornea 3 mm, 7 mm, 5 mm. Radius of curvature 7.4 mm, 7.4 mm, 7.8. The radius of curvature of the posterior surface. If it is less, means it is steeper, means the bridging substance is required, and if it is more, radius of curvature means it is less convex or less steeper and no bridging substance is required. Coupling fluid, required, not required. Dynamic gonioscopy, manipulation, and indentation. Figure 5, gonioscopy being performed with a Zeiss 4 mirror lens. Anyways, the technique, I'm gonna add the video of the technique with Zeiss 4 mirror lens from www.gonioscopy.org. Figure 6, gonioscopic anatomy of the angle of the anterior chamber. Short baseline, typically Schlimm's canal, scleral spine, ciliary body. Now I'll read in short the anatomy of the limbus. Corneoscleral limbus. The corneoscleral limbus is a translucent transitional zone between the cornea and the sclera, approximately 1.5 mm in diameter between the clear cornea and opaque sclera, but wider in the vertical plane. Vertical plane is wider, that is 2 mm. Centrally, the corneal-limbal junction is demarcated by a line joining the termination of the Bowman's membrane. Centrally means anteriorly. Line joining the Bowman's layer to the termination of the Descemet's membrane, that is Shawley's line. Internally. Peripherally, the sclerolimbal junction is demarcated by a parallel line passing through the scleral spur. So, in short, from the Shawley's line to the scleral spur. Parallel lines. The limbus can be divided into 3 zones depending on the depth. The deep limbus, mid limbus, and the superficial limbus. The deep limbus, which contains the tubercular meshwork and Schlimm's canal. The deep limbus that bears what? Deep limbus is the inner surface of the limbus, that is marked by the circle, that is marked by the groove, and that groove is called as scleral sulcus, and it is breached by the tubercular meshwork and converts it into the Schlimm's canal. And hence, the deep limbus, they have said here, it contains the tubercular meshwork and Schlimm's canal. It's nothing but the scleral groove converted into Schlimm's canal by the tubercular meshwork. The mid limbus containing the transitional corneoscleral stroma, which projects with a conoid profile into the scleral limbus. It also contains the intrascleral venous plexus. The mid limbus transitional zone. The mid limbus, it contains the transitional corneoscleral stroma and the intrascleral venous plexus. The superficial limbus, which consists of the episclera, Tinen's capsule, the conjunctival stroma, and the limbal conjunctival epithelium with its specialized anatomical features. The superficial limbus, it consists of what? Episclera, then Tinen's capsule, then conjunctival stroma, then conjunctival epithelium with its specialized anatomical features. That was all about the corneoscleral limbus anatomy related to the what? Related to the anterior chamber angle and its drainage. So, corneal limbus, it is the transitional translucent zone between the transparent cornea and opaque sclera, and it is 2 mm wide vertically. Its diameter is 1.5 mm wider in the vertical plane, around 2 mm, and it is demarcated anterior centrally by the Schallbase line, that is the termination of the bonus membrane and Descemet's membrane, and posteriorly or peripherally by the scleral spur, the parallel line passing through the scleral spur. And scleral spur, it's nothing but the projecting part or the posterior lip of the scleral sulcus that is present on the inner surface of the limbus. It is a circular groove. Now, the limbus is divided into 3 parts. Like these are the layers from deeper side to the superficial side. So it is the deep limbus, mid limbus, and superficial limbus. The deep limbus, it is demarcated by the scleral sulcus. It is the groove, and that is converted into the Schlemm's canal by the bridging trabecular meshwork. So it contains the trabecular meshwork, Schlemm's canal. And the mid limbus, it contains the corneoscleral transitional zone, the corneoscleral stroma, the transitional stroma. It contains the transitional corneoscleral stroma, also the intrascleral venous plexus, and the superficial limbus, it contains episclera, tenon's capsule, conjunctival stroma, and conjunctival epithelium. So that was about the corneoscleral limbus in short. That was about the limbus anatomy related to the anatomy of the antechamber angle. It's from the Wolff's anatomy. It is present in chapter 8, antechamber angle anatomy. Then again, I would like to read internal scleral sulcus. What is it? The scleral sulcus. It is a circular groove on the inner aspect of corneoscleral limbus, extended from the termination of Descemet's membrane anteriorly, demarcated by the Schallbase ring, to the scleral spur posteriorly. The portion of the spur which forms the posterior boundary of the sulcus is sometimes called scleral roll. The sulcus completely accommodates the canal of Schlemm externally and the corneoscleral portion of the trabecular meshwork internally. So the sulcus, it accommodates the canal of Schlemm. How it accommodates? It is breached by the trabecular meshwork and it is converted into the Schlemm's canal. And the corneoscleral portion of the trabecular meshwork internally. So, trabecular meshwork converts it into Schlemm's canal. So, on the internal aspect, it's the trabecular meshwork, and on the superficial aspect, it's the Schlemm's canal. So, that was about the internal scleral sulcus. To make you understand scleral spur better, I had to explain you what is scleral sulcus, and to make you understand scleral sulcus better, I had to tell you the limbus anatomy in short related to the anatomy of the antechamber angle, and I read the anatomy from the Wolff's Anatomy 8th edition. So I guess it's enough for today. It's already 40 minutes past and I have to stop here. I hope you have understood it nicely. Tomorrow I'll cover the rest of the Arwind's. I'll just complete the Gonioscopy from the Arwind's textbook of glaucoma, and the day after tomorrow I'll add the pictures and the videos for your and my better understanding. Thank you so much for listening to me patiently. Have a good night. Bye. I'm just getting it. Ouch!
This section will discuss the Goldmann lens and variations of this lens, such as the MagnaView lens, the Rich lens, etc. These lenses provide a beautiful view of the iridocorneal angle. They have a large area of contact and vault over the cornea. Because of this, they need to be filled with a methylcellulose coupling solution. They are excellent lenses to be used for surgical procedures in the angle, such as trabeculoplasty, and many of the clips, in fact most of the clips in this web page, are photographed through the MagnaView lens, which is a one-mirror variation of the Goldmann lens. However, for daily use they are less convenient than a four-mirror lens, and anything that's less convenient tends to be used less often. Additionally, the methylcellulose degrades the images of subsequent photographs and makes subsequent perimetry challenging for the patient. One begins the examination by filling the concavity of the lens with methylcellulose. It's important that there are no bubbles in the fluid. This can be done by beginning a stream of the coupling material on a tissue and then transferring the stream to the lens concavity. Alternatively, one can remove the dropper cap and deliver a glob of methylcellulose into the lens concavity. The patient is instructed to look up, and the inferior part of the lens is placed against the lower portion of the globe. The lens is tilted up and the patient is instructed to look straight ahead. I always warn the patient that they will feel material running down their cheek, and I let them know that this material is not harmful. In fact, mouthwash is often made with methylcellulose. I start by looking at the 12 o'clock mirror, which allows me to look at the inferior angle, the deepest and most pigmented portion of the angle. I then rotate the lens clockwise and record the findings in a clockwise manner, 360 degrees around the iridocorneal angle. I find that if I hold the lens with 3 fingers and brace my other 2 fingers against the patient's face, that I can rotate the lens continuously without using the second hand and letting go of the slit lamp controls. This does take a little bit of practice. At the end of the examination, the lens is often sucked onto the patient's eye, and one can remove it simply by pushing against the patient's eye with the index finger and breaking this seal. This clip will center on the 4-mirror lens. The prototype 4-mirror lens, the Zeiss lens, is no longer produced. So this clip will be about the Posner lens, the Volk G lens, Sussman lenses, and similar lenses. In the 4-mirror lenses, all 4 mirrors point towards the iridocorneal angle. There are no mirrors that are designed to look at the peripheral retina. These lenses have a small area of contact. You can see cornea around the lens when it's being used, and they have a relatively flat area of contact. The advantage of this lens is that it does not require any methylcellulose as a coupling solution, so that it is very fast to do gonioscopy once one becomes skilled. Also, there is no methylcellulose to degrade subsequent perimetry or photography. I believe that this is the best lens for routine use. It is the most difficult lens to master, but it is worth learning to master this lens. Additionally, this lens can be used for indentation gonioscopy, a very valuable tool that is discussed in the section on techniques for difficult angles. This lens is held between the thumb and index finger. The remaining fingers are used to brace the hand against the patient's cheek. This will steady the hand and allow the examiner to keep up with any small patient movements. The lens is held lightly, and this is one of the hardest aspects of this kind of a lens. When I perform gonioscopy with a 4-mirror lens, there's constantly air darting in and out underneath the lens, letting me know that I'm not pushing too hard. If I'm pushing too hard, I will artificially open the angle, as in indentation gonioscopy. Certainly one should not see corneal folds during gonioscopy unless one is intentionally indenting the eye. The lens is held square to the eye. This is the most comfortable position for the patient. If the lens is held in a diamond-like configuration, the edges of the lens are uncomfortable against the patient's lids. I always begin by looking in the superior mirror. This provides a view of the inferior iridocorneal angle, which is the deepest and the most pigmented part of the iridocorneal angle. The pigment helps to define the angle structures and allows one to become oriented to this particular patient's anatomy. The upper and lower mirrors are also the easiest to use to identify the corneal wedge, which is discussed in the section on difficult angles. One can then look in each of the 4 mirrors in turn, noting any abnormalities and recording them, remembering that the view is a mirror image. There are small portions of the angle that are missed by holding the lens still and looking in only the 4 mirrors. One can see these other small portions of the angle simply by rotating the lens a few degrees and re-looking in the 4 mirrors. Tall clinicians might find the handle of the Zeiss or Posner lens to be awkward. The Sussman lens might be a good alternative because it does not have a handle. The Sussman lens is an excellent lens, but I find that the long barrel makes it difficult for me to offset the light source from my oculars. For tall clinicians, it is a wonderful lens. This sequence will show general exam techniques. We'll then have separate clips to show specific techniques for the 4-mirror lens and the 3-mirror lens. It is important that the eyes are topically anesthetized. It's also important that the patient's head is set up in a way that allows the exam to be performed as easily as possible. The patient's head needs to be firmly braced against the forehead band. The eye should be aligned with the canthal mark to allow full up and down excursion of the slit lamp. This is especially important for gonioscopy to allow the examiner to use the upper and lower mirrors. We typically begin with the slit lamp power at 10x and can increase the power as needed throughout the examination. The room light should be dimmed for gonioscopy. In this video, obviously the room is bright to allow the video to be performed, but typically the room light should be down. Similarly, the slit beam should be short so that it does not shine into and constrict the pupil, artificially opening the iridocorneal angle. It is important that the patient be relaxed. The examiner should be honest, but not too descriptive of the procedure. I usually say that this lens will come close to your eye, but will not hurt your eye, and you will feel it touch your eyelashes. This is honest and prepares them for the sensation of the lens touching their eyelids, but is not fully descriptive. Saying something like this sharp piece of glass will be lying against your eye is only going to make the patient anxious and is not beneficial. It is important to brace your elbow. Gonioscopy is challenging enough without making it more difficult by having your elbow unsupported. For people with short arms, having a block of some sort under the elbow is very helpful.
This is the first video in this series of Science in Glaucoma. Schwalb's line is the starting landmark when doing gonioscopy. In this photo of a model, this is the location of the Schwalb's line. Behind it you have the trabecular meshwork, then the scleral sphere. Here you have the ciliary recess and iris. We all know that aqueous passes through the trabecular meshwork to reach to the canal schlemm. So you need to start by identifying the Schwalb's line so you can see whether the trabecular meshwork is visible or not. So this is the starting point. Here, this is the cornea. Section in a cornea on a slit lamp, you're going to see inner and outer surface and in between translucent tissue. On the other hand, back here in the area of the trabecular meshwork and the scleral zone, you're going to see only inner surface. This is the location of the Schwalb's line between the cornea with inner and outer surface and translucent in between, and sclera, which is opaque. This is the extent of the Schwalb's line. Actually, this model is not accurate. It should be like that. We all know that the cornea wedge is inserted into the opaque sclera. So in reality, you are going to see this area translucent, this area opaque. If you follow to the inner surface, this is the location of the Schwalb's line. I put the model on a slit lamp. You can see in the upper part section in the cornea with inner and outer surface, while in the lower part only inner surface. This is the trabecular meshwork. It's opaque. And this is the location of the Schwalb's line. This is the starting point. In a patient, this is the way it's going to look. This is the wedge shape of the cornea. If you follow this wedge, this is the location of the Schwalb's line. You have to identify it by a section. This point here, where there is translucent in between anteriorly and opaque posteriorly. Once you see this, you can identify the rest of angle structures. Thank you for your attention.
The corneal wedge described by Posner and Gorin in 1967 is formed by the sharp transition of clear cornea to opaque sclera, with the tip of the wedge indicating the level of Schwalbe's line. It is easiest to learn in a wide open angle where you understand the anatomy already. One uses a slit beam angled in at about 20 degrees, a high intensity light, and narrowing the beam, one can identify the corneal wedge and the level of Schwalb's line. The technique is not easy to learn, but once mastered will become very useful in identifying questionable angles. You might wonder whether this is an open angle with no trabecular pigmentation or synechial closure. One uses the corneal wedge to answer the question. High intensity light, and the wedge indicates the level of Schwalbe's line. The angle is wide open. In this next case, the view is hazy because of corneal edema, raised intraocular pressure, and we use the wedge technique to find the level of Schwalbe's line. High intensity light, a narrow beam, and the wedge indicates there's definite synechial closure.